Welcome to the Birth Squad, the podcast designed to empower birthing individuals with real insights from two Black female physicians. We're here to guide you through your health journey, one episode at a time. I'm Dr. Kamisha Thomas.
And I'm Dr. Ijalma Bello. We are two OBGYNs and longtime best friends, and we're here to help navigate you through the world of reproductive health.
Real women, real stories, real experts, and the facts you need to know.
Tune in every other Sunday, and don't forget to like, follow, and subscribe.
Ready to join the squad? Let's get into it. Welcome to this episode of the Birth Squad podcast. Please be advised that the topics discussed in this episode may be sensitive and could be triggering to those who are currently experiencing infertility or who have been through related struggles. Listener discretion is advised. The information shared is for educational purposes only. We encourage anyone affected by infertility to seek support from a healthcare professional or a counselor. Now get ready for this week's episode. Well, welcome back to another amazing episode of the Birth Squad podcast. Again, we have a very special guest, someone that I've known for many years. We actually trained together in residency. And so this is Dr. Rachel Mandelbaum. Thank you for coming on the show, Rachel.
Thanks for having me. I'm so excited to be here and have followed, your journey creating this podcast. And I think it's just so amazing that you're offering this resource for women and really opening conversation to so many issues that are so important in OBGYN.
Thank you so much. But you are also doing amazing work. So I wanted to start about having you discuss about your background and what led you to specialize in REI or fertility.
Yeah, so it was definitely a long kind of roundabout road. So I grew up with two doctors as parents. So I knew what this life looked like. But I really wanted something that felt not like a job, like a calling. And I really felt like I wanted to be, if I was leaving my family, if I was devoting all my time to something, I wanted it to feel so important that it was worth it. And I feel like this whole long circuitous journey has gotten me to very much that point where I feel like I love what I do every day. Fertility medicine, there's really no field that has changed like this field in the past 40 years. I mean, we didn't even exist, right? The first IVF babies in their 50s. So, this field has moved so fast. We've learned so much, but there's still so much left that we don't know. I mean, reproduction happens in a black box. And so these very vital questions of like, where do we come from as a species, right? What is, when does humanity start, right? These very vital questions that we are really still living in the Stone Ages in terms of how close we are to being able to answer some of these key questions that we know about other species, but it's really difficult from a research perspective to answer them about humans because it's impossible to study, right? It happens in the black box of somebody's uterus and we have research limitations, et cetera. But it really excited me that so much is left unanswered. I felt like, oh my gosh, I can really help push the field forward and be a part of that. And that was really exciting to me. And then simultaneously, I really felt myself bonding and really felt it like a huge personal rewarding experience working with patients who had infertility or pregnancy loss. I felt like that was something that I so identified with at my core, like what patients were going through. The highs are so high in this field, but the lows are so low. And so you really, when you're working with these patients, have to be there for the roller coaster and for every moment. And so I feel like that's, I guess to bring it full circle, that's totally my calling,
So Rachel, one question that we always ask our guest is, tell us about your journey to motherhood. Do you mind sharing a little bit about that?
I'm happy to. Okay. So when we were residents together, I am married to an orthopedic surgeon. So creating a family was never something simple. Like my husband and I passed each other in the night. We, rarely were in the same place at the same time with night shifts and everything. But we always knew we wanted a bigger family and that creating that family would be a little bit more challenging just given our jobs. So I knew that I was staying where we did residency at USC for fertility fellowship. And I, thought, okay, my husband I knew he was leaving Los Angeles for fellowship and my thought was, okay, let's, freeze some embryos. I know the realities of female ovarian aging, which we can talk about later, but I know that, if I'm trying to have a baby in my late 30s, that may not be an easy feat. Being a physician is like the number one risk factor for infertility. And so I was like, let me be proactive and we'll freeze some embryos. And in the course of that, I ended up finding out that I had really, really low ovarian reserve, so low number of eggs. And I'd had an IUD in for forever. So I never knew anything about my periods. Really, like my reproductive tract was something that I had managed very well with birth control and an IUD, and I knew nothing about. But when I found out that I had a really low egg count, that felt like earth shattering to me. And I knew better. I knew that egg count is not correlated with fertility, but it felt like something about, it felt like that family that I thought, okay, I'm just going to snap my fingers and that will happen, which everybody believes whether or not you're a fertility specialist or not. I felt like that was really in question, and it felt very violating. I felt devastated. And so I was like, wow, okay, I'm in this. I'm going to freeze embryos, right? This might be my shot here to create this bigger family that I want, but ended up pulling my IUD at that time and had a surprise pregnancy as an OBGYN, which was fine. I mean, we had thought about it, and he's our beautiful, happy little act that we love so much. So Kamisha's, had one of my first ultrasounds, my little yolk sac. So, I'm kind of the poster child for this conversation I have with patients every single day, which is that egg count does not correlate with your fertility. And I share my own story with my patients all the time, just to say that, as long as you're ovulating an egg each month, meaning getting a period, it doesn't matter how many came to that competition to be that one egg, right? It just matters that you're releasing an egg each month, and it's all about the quality of that egg. And I was young, but it was a little bit bittersweet because I felt like, okay, but we really want this bigger family. And, I didn't get to put anything on ice. So then I revisited that journey after I had my first son, Aaron. We went through the IVF process. It kind of was meant to be because it was in that process that I developed needle-free IVF and kind of got to test this different protocol, IVF protocol, on myself that I've now published on. So it really felt like it was meant to be that timing, because I just got to use myself as a guinea pig for two things that I was really passionate about studying. And the cycle went great. We got very lucky and made some nice embryos, even though quantity was very low. And that's the thing when you're young and you have quality on your side, you can deal with low numbers. And then had my second son, Miles. And now we're kind of, in the thick of building a fertility practice. And baby number 3 is hopefully a frozen little embryo and waiting for when the time is right. I'll need a girl at some point.
Wow, Rachel really shared some great information about her experience, but let's break down some of these concepts that she mentioned.
Yeah, let's start with the basics, because let's be honest, women are complicated. When a woman's body is ovulating, what's actually happening with those eggs?
Well, every month, just like clockwork, one of those eggs comes from either the left or the right ovary, and it gets the golden ticket to be released from the ovary. It's like a VIP pass. It's ready to party in the fallopian tube, just waiting for the sperm to show up for the ultimate meet and greet.
So it's like the egg is on the red carpet, waiting for its celebrity guest, the sperm, to make an appearance.
Exactly. And then the sperm's like, oh, hey, I've been waiting for you. And boom, fertilization happens if everything just lines up all right.
But what if you want to freeze those eggs for later, Ijama? I mean, that sounds like the perfect plan, right?
Oh, yes, egg freezing. Now, that's like putting your eggs in a literal time capsule. So when you freeze your eggs, you're basically putting them in the freezer, just hanging out in its suspended animation, waiting for a super date in the future to shine.
In general, you freeze your eggs at a younger age, at a healthier stage. Then you thaw them out when you're ready to have a baby.
Right. But then how does IVF fit into all of this?
IVF is like the ultimate fertility hack. If your egg and sperm need a little help meeting each other, IVF is here to step in. So first, we might retrieve a bunch of eggs from the ovaries. Think of it like grocery shopping, like a spree. But instead of apples, we're shopping for eggs.
Yeah, and we're not just trying to grab one egg. We're going for the whole dozen.
Exactly. Think Costco. And then we take those eggs and we fertilize them with sperm in the lab. It's like a controlled high-tech party. After the eggs get fertilized, we watch them develop into embryos. And then we pick the best one to pop back into the uterus. It's like matchmaking, but with much higher stakes.
Oh, wow. So it's like dating, but instead of a dinner table, you're going straight to the IVF clinic.
Right. And sometimes we even get multiple embryos, and then we have the option to freeze the extras for later. So you've got backup plans. It's like a fertility safety net.
Yes. So IVF is like the Tinder of the fertility world. It's like finding your perfect match and swiping right.
Exactly. Just swipe right on that embryo, and you just might get a baby 9 months later.
Wow. IVF really is the ultimate wingman for couples who need a little bit of help.
All right, Birth Squad, let's get back to Rachel. I mean, thank you so much for sharing that. And you brought up some really good points that I want us to make sure we talk about. Number one, obviously tell us more about needle-free IVF, right? Like I personally also benefited from doing an egg retrieval with needle-free IVF. And let me tell you, it's life-changing. So I want you to tell us more about that. But also, you brought up this really good point about fertility testing, right? We get asked all the time by patients, I just want to know what my egg count is, or I want to know what my anti-Müllerian hormone level is. I want to know, can I have kids? So if you could, I know I threw some big questions at you. Can you tell us a little bit about needle-free IVF and then about who should get tested and what does that testing look like?
Yeah. I'm going to answer the who should get tested because I think it's a natural progression. So I think I'm a big believer that knowledge is power, right? You have to be able to make informed decisions, right, about your fertility. And I really think now with the technology we have, we can change the way we think about family building. And particularly for people that think that they want a bigger family, we can prepare for that and enter your 30s, your mid 30s, your late 30s with a plan to make that happen with fertility technology. Now, part of that is knowing your egg count. Now, it's so important that when you get your egg count tested, that you have the right counseling, right? That you really understand what that means and most importantly, what it does not mean. So there is no test for your fertility, right? I can't tell you if you're the most fertile person on the planet or if you are going to have infertility. I can never tell anybody that because the only test for fertility is actually trying to get pregnant and seeing if it happens, right? Now, what egg count does tell you is it tells you how you will do if you are to need fertility treatment. So in the chance that you are somebody that has trouble conceiving, if you then are to go seek out IVF, and I don't mean insemination. So it also has nothing to do with your prognosis with intrauterine inseminations or kind of using the body's natural mechanism to achieve a pregnancy. It really only applies to IVF. And this is because IVF is all about using numbers of eggs in the IVF lab, right? When we take 10 eggs in the IVF lab, it's like we're taking 10 months of ovulations, exposing those 10 eggs to sperm, and then seeing what happens. Which ones fertilize, which ones create embryos, which of those embryos lead to a pregnancy, and then which pregnancies lead to a birth, right? It's this huge funnel in natural reproduction that I think people forget about sometimes, that every egg doesn't fertilize. Not every fertilized egg leads to an embryo. Not every embryo leads to a pregnancy, and not every pregnancy results in a baby. And that's just natural reproduction. It's very inefficient. So when we're talking about egg count, right, the people who have a higher egg count, right, are people where IVF is going to be more efficient. Now, notice I didn't say successful because it's really about efficiency. If you have a low egg count, well, you can do several cycles of IVF and get to the same number as maybe the person who had a ton of eggs and got 30 with one cycle. It's just going to take a lot of cycles. And for most people, that isn't necessarily feasible because it's a lot to put your body through emotionally, physically, and then a lot of money. But it just makes it more efficient if you have a higher egg count. Really the world capitalized upon the ability to measure AMH or anti-Müllerian hormone as any indicator of something that could potentially be related to your fertility, right? And it became commercialized as a test, and a lot of people order these tests through companies like Modern Fertility. And in some ways, I love that people are doing this, right? Because they are at least able to have this tidbit of information of, oh, if I were to need fertility treatment later, am I someone who would kind of be it would be less efficient and therefore I should kind of prepare for that process earlier if I were to need that? Or am I someone that I have a good egg count and maybe these next 2, 3 years in terms of egg quality aren't making too much difference and I have a little more flexibility, right? Nobody's able to tell you that, but that's kind of the way the thinking goes, right? Where it becomes problematic is sometimes a young person may check their AMH, find out it's low, like me, right? And that can cause a lot of undue anxiety of, oh my God, I'm not going to be able to get pregnant. I'm not going to be able to have the family I want. And that's not true. But, it might make them take some extra steps to ensure that family they want, like I did. Now, on the converse, if somebody who's 40 checks their AMH and it's high, right, and they find out they have a high egg count, well, that doesn't mean they have the ovaries of a 20-year-old, right? Their egg quality is still that of a 40-year-old. So it can provide some very false reassurance to people when it comes back high or normal, when age is really the most important predictor of egg quality. And getting pregnant in our late 30s, early 40s can be quite difficult because of these changes, age-related changes in egg quality. Okay, so that was the long-winded answer to checking your ovarian reserve.
Wait, hold up. So Rachel is saying that anti-Mullerian hormone levels don't really explain how fertile you are?
That's right, Kamisha. It's not as simple as my AMH levels are high, I'm good to go. Or no, my AMH is low, I'm doomed. The number just tells you something about your outcome during an egg retrieval. It does not tell you the full picture of your fertility or guarantee a pregnancy.
So AMH tells us about how many eggs we might retrieve from one retrieval cycle, but that's not the same as fertility?
Exactly. It's like saying you have a lot of eggs in the basket, but that doesn't mean all of those eggs are good for a successful pregnancy or that you won't get any eggs at all. It just means that it might take more cycles to get to a larger number of eggs.
Got it. So what's the difference between AMH and, say, an antral follicle count? Is that a better indicator?
So an antral follicle count is definitely a more direct look at what's going on in your ovaries. It's basically like a count of the little follicles that in turn become eggs. It's like checking the stock about how many eggs you potentially have in the pipeline right now.
So it's like an actual inventory of my egg potential?
Yep, exactly. It's like a count of the follicles that are visible on the ultrasound. But even then, not all those follicles are going to make it to the finish line. Some will grow, some won't, and some may not even be capable of being fertilized.
Okay, so I'm starting to get this. AMH is more like a snapshot of your potential during an egg retrieval, while antral follicle count is like checking your stock. But neither of those tell you how likely you are to get pregnant, right?
Exactly. And Kamisha, I know you know this, but what they do is they give you clues about your fertility potential, especially if you're considering fertility treatments like IVF. But remember, in the end, fertility is a lot more than just the numbers. It's about the egg quality, the sperm quality, and timing, about them all coming together for that successful pregnancy.
Yes. All right, y'all. Let's see what Rachel has to share with us about needle-free IVF.
And then you asked me about needle-free IVF, which is my baby and has been, like 6, 7 years in the making. So this is something I kind of dreamt up back when Kamisha and I were residents. I hate needles. I'm like the doctor that, like, when they're coming at me with that flu shot, I'm like, just like, oh my gosh, trying to get away from it. And it's totally irrational fear, I know. And it has improved lately, but still, I hate needles. So when I was going through that process of thinking, oh, I'm gonna, need to freeze some embryos. And then that process got a little bit derailed by my first son. I thought, oh my God, I'm gonna have to inject myself, somewhere between 2 to 4 times a day. How am I possibly gonna do that? And at the time I was working in high risk OB clinic. And I was working with a doctor that Kamisha and I know and love so much, who works with patients who have diabetes. And I saw how happy the type 1 diabetics were when they got an insulin pump, when they didn't have to inject themselves so many times a day. And I was like, oh my gosh, well, I'm having to inject myself so many times a day over here. Why can't I get one of those? And so it became like a little dream. Like, why can't we do this for IVF? And I think I kind of had that experience because I wasn't in fertility yet. I was an OBGYN resident. So I had this experience of kind of looking at IVF as an outsider, right? Like as a patient. So anyway, then when it came time, after I had my first son and it came time to do my IVF cycle, I kind of got everything in order to be able to trial this idea on myself. So I did needle-free IVF on myself first and really got to try it out, got to, tweak how I wanted it, figure out how I was going to prepare the medications to go through it. And it went great. I measured my FSH levels, my hormone levels throughout the entire cycle. It went great. And that was really the door to the impetus to start a clinical trial comparing this, what I call subcutaneous catheter. It's a small quarter-sized device or like a port that's a sticker that sticks on your abdomen. Actually, I have one right here. I'll show you. It looks like this. It sticks on your abdomen and it has, I don't know if you can see down here, it has a small tiny plastic cannula that sits right under your skin and delivers the medications. And when it's time to give medications, you just unplug this piece and you can attach a tubing piece that twists onto a syringe at this end to give medications. So it really just removes the injection piece of it. And so then I did this clinical trial comparing it to women who did needle injection, and we found that the hormone levels were exactly the same, which we knew. This is why it works for diabetics, why it works for people using other medications. We've just never applied this to IVF before. But all of those patients did great. And so I did that trial in my fellowship training. And then now that I'm practicing, this is like a dream come true. I've been able to offer it to my patients. I would say now about like 70% of my patients use it. For the ones that don't care about needles at all, then they might as well not wear something. But for the ones who would prefer not to inject themselves, and whether it's people who have like an extreme needle phobia like me, or people who just are like, meh, if I don't have to, I don't want to. I think it's made a positive impact on a lot of my patients' journeys. So it's been quite a journey, and it's fun to see it fully in action.
What an awesome innovation. Like the field is so lucky to have you, and you are patient zero.
Yeah.
You found something for yourself, and it really it's changing lives. I mean, I wish I had that available as well. And I just wanted to pivot now to infertility in general is like so deeply personal. It's often such a frustrating journey for a lot of people. What are the most common causes of infertility that you see in your practice?
Yeah. So, with infertility, you kind of have to go stepwise, right? You have to think, okay, like what's the recipe to create a pregnancy and what can go wrong, along the way. So you really can divide it up into something that's wrong with the sperm, right? Something that's wrong with the egg. And there's, several things with the egg that are important, right? Is the egg actually being released? So I see a ton of what we call ovulatory factor infertility, right? Women who have polycystic ovary syndrome or hypothalamic amenorrhea, where their brain isn't producing the hormones that we need to grow an egg to the point of ovulation. So is there even an egg being released? And kind of the biggest indicator of that is are you getting a period? And the egg also has to be high quality. So that's where aging comes in, right? So that's where female aging comes in. And I see a lot of infertility related to female aging and kind of those egg quality issues that contribute to infertility and miscarriage. And then the question is, are the fallopian tubes open? That's where egg and sperm come together and where fertilization happens. And the fallopian tube, I think, is kind of like the unsung hero. We don't talk about it that often, but it plays such a pivotal role in creating a pregnancy. That's where egg and sperm have to meet. And then there are these tiny little hair-like cells that have to push an embryo along with fluid and mucus along the fallopian tube to the uterus to implant. And that's where really the majority of pregnancies drop off, is in the fallopian tube before implantation. So we have to make sure that there's a place for egg and sperm to meet, and that on a microscopic level, those tubes are functioning normally to get the embryo to the uterus. And when that goes wrong, that's when we start seeing things like ectopic pregnancies, etc. And then the uterus, right? Is there something like fibroids or polyps or something that is affecting the embryo's ability to implant and grow? So, that's how we kind of categorize infertility. And some people check multiple of those boxes and some people check none, right? And so that's kind of the most frustrating group of patients, or when we don't have an answer, because again, like I talked about before, reproduction kind of happens in this black box. And sometimes even through our infertility workup, we don't have an answer. Now, luckily for those people, our treatments are usually successful in treating infertility, but I think it's very frustrating to not have an answer.
All right. So, Rachel mentioned a few reasons why people might struggle with infertility. We're talking male factor, egg quality, ovulation dysfunction, uterine issues, and fallopian tube problems. Let's start by breaking down male factor.
Yes, the guys. So, male factor infertility basically means that the sperm isn't quite pulling its weight. It could be due to low sperm count, slower swimmers, or poor quality. Not exactly the Michael Phelps of sperm.
Ouch. So, what puts guys at risk for this?
So, there's a few things: lifestyle choices like smoking, excessive drinking, and let's not forget about age. Sperm quality can dip a little bit as men get older, too.
Next up, let's break down egg quality.
Yes, so as you get older, the egg quality tends to decrease. That's why women in their 20s and their 30s generally have the best quality eggs. But by 35 and older, it is a different story.
Other risk factors? Well, poor diet, smoking, and even stress can mess with your egg quality. So listen up, eat your vegetables, get that beauty sleep, and if you can, try to relax.
Next up, ovulation dysfunction as a cause of infertility. If your ovaries aren't actually releasing eggs like they should, you're also going to have a hard time getting pregnant.
If you're not ovulating, no eggs are available for fertilization. Conditions like PCOS, also known as polycystic ovarian syndrome, are big offenders here.
Yes, so what are some red flags of ovulation dysfunction?
Well, irregular periods, weight gain, acne, and excessive hair growth on your face or your back, places that you would not normally grow hair or have acne. Basically, your body's way of saying, I'm confused, girl.
Okay, so next up is uterine issues. We're talking fibroids, polyps, and other things that could be hanging out in your uterus and making it hard for fertility to happen.
Yep, fibroids and polyps are like unwanted house guests. They can mess with implantation or even block the way for sperm to reach the egg. And some women might not even know they have them until they try to conceive. So, how do you know if you've got some uninvited guests in your uterus?
Yeah, so signs like heavy periods, pain during intercourse, and pelvic pressure may be signs. And unfortunately, Black women especially have a higher risk of developing fibroids. But honestly, an ultrasound is your best way to see what's going on in there.
And last but not least, fallopian tube issues. You know, the tubes that are supposed to be the highway for the egg and sperm to meet.
Absolutely. They are the unspoken hero of the whole fertility journey, because if they're blocked or damaged, we have a big problem.
So, what causes those tubes to get blocked?
So things like pelvic infection, endometriosis, cigarette smoking, or even previous surgeries can mess with the tubes. If they're blocked or scarred, you can't get to the egg where it needs to go, and the sperm may not be able to reach the egg as well.
Sounds like a whole lot of roadblocks. So, if you're dealing with any of these, what's the next step?
First of all, don't freak out. There's a lot of testing and treatment options out there. And sometimes the journey to pregnancy isn't just a straight line. It can be full of twists, turns, and detours. But with the right support, you can get to your destination.
Absolutely. So, if you've got any of these risk factors, make sure you're talking to your doctor because a little early intervention can go a long way.
So now let's get back to Rachel as she concludes her episode by delving into the nitty-gritty details of evaluating and treating infertility, as well as how we can support each other during the process.
Thank you for that. That's really helpful because a lot of people will come to us at the generalist level and say, I have PCOS, I have endometriosis, and is this contributing to my infertility? And that's a conversation that we have a lot of times with people. But I think the piece that is also important that you mentioned is it's not always us, right?
Yeah.
That men play a role. And so I can't encourage women enough to if you are starting the preconception journey, a part of that is to get your partner plugged into the health system. Because if you're not healthy, if they're not healthy, then that just delays that process. So thank you for mentioning that.
Yeah, the sperm is, 30 to 50% of couples that have infertility, there's an issue with the sperm. So it is a huge part of infertility care that we have a semen analysis and that the male partner is kind of doing their part in checking to make sure that's okay. And, I unfortunately see sometimes some resistance there. And I think it's such an important thing that we treat patients as if they are presenting as a couple, that we treat them as a couple, not just the female. I mean, we're OBGYN, so we're used to treating females, but with fertility, it really is quote unquote a team sport, right? And so we really have to explore all angles there.
Yeah, that's so true. And you're right. Sometimes that is the biggest barrier is to get that partner involved because they think it's just about the female. So I think reaffirming that, reinforcing that is really important.
Yeah, and I think some of it, I mean, I give them some credit. It's not the most, a lot of guys feel embarrassment or something like that. It's a strange experience. I remember when I even asked my husband to come produce a sample for a semen analysis, and then later for, when we actually made embryos, he was like, I have to do what and where? So, I understand that, right? And I think people come through my door and are very surprised at the questions that I ask couples, about when they have sex and how they have sex and all of these things. But it's all really important to a fertility journey and something that, I'm very used to discussing. I ask those questions all day, every day. Nothing can surprise me, right? But I understand that it's something that we don't grow up talking about. It's not something you are asked or talk about every day.
Yeah. And I think, speaking of some barriers, like we talk about how sometimes your like partners can be a barrier to getting care, some of the data also shows us that like there's social determinants of health that affect it. Like Black women tend to experience higher rates of infertility, but are less likely to be able to get like timely or appropriate care. What do you think are some of the reasons that contribute to this kind of disparity that you may see?
Oh my gosh, infertility care is one of those where I really think disparities when it comes to race are just really not addressed to the degree that they should be. And we are starting to have those conversations, but I think for a long time, infertility care is something that people have a lot of trouble accessing, right? It's not something that has been applied to what we think is universal health care that everybody should have access to. I mean, Kamisha, you and I trained at a county hospital. We can't even get them to, if any note, said infertility, right? It was very taboo. And so for a field like fertility, that's where we're going to see disparities kind of maximized, right? Because even our state healthcare system doesn't view it as important or something that people should have a right to have fertility care to build their families. So we just see disparities at every level here, accessing it, people being able to even just come in my door to, have an initial consult, to then being able to access treatment, timely treatment, and even infertility outcomes when they do undergo treatment. And that just really gets back to social determinants of health and really all these things that we think are, lifestyle factors that affect fertility.
Those are some really good points, and I think you touched on all the key factors that can contribute. One question I have, and it's for our listeners who may not be familiar with some of the, acronyms. What is IUI? What is IVF? Can you just kind of break that down briefly?
Yeah. So those are kind of our two treatment strategies for fertility, right? We can, spend all this time doing a workup and trying to figure out what's going wrong. As I mentioned, sometimes we don't have an answer, but then we look towards treatment, right? And the first strategy, the first category, if you will, is intrauterine insemination, right? And basically what that is it's using the machinery that our body naturally uses to create a pregnancy, meaning egg and sperm meet in the fallopian tubes, but optimizing it, right? Often we'll use oral medications like Clomid to get the ovaries to grow instead of just one egg per month, to get maybe somewhere on the order of 2 to 4 eggs per month. So instead of just one opportunity, maybe there's 2 to 4 opportunities of eggs that can be fertilized and lead to a pregnancy. And then we're taking a kind of concentrated motile, meaning the sperm are swimming really strongly and kind of the good sperm, right? Because the important thing to remember about sperm is the vast majority of a male sperm are abnormal. So there's a huge amount of attrition with sperm after they're ejaculated in the vagina, and they have to make this big long trek, and 99.99% of them are lost, and only a very small fraction of them actually make it to where the egg is in the fallopian tube. So we take this very motile concentrated sperm sample and put it up at the top of the uterus closer to where it needs to go. So we're kind of eliminating, 2/3 of that swim there, right? So the way I explain is really we're using the same machinery that a couple has been using on a monthly basis to try to achieve pregnancy, but we're optimizing it, right? We're seeing if maybe we just haven't hit that good egg, right? Because we just are having one opportunity per month. And if that swim is, if there's like a subtle sperm fact where the sperm isn't able to, in sufficient numbers, really reach the egg. Now you can imagine that it is, because it's a less invasive treatment, it's also less successful. So IUI can be very frustrating for some couples because after a couple has been trying to get pregnant for about a year, right? At that point, about 80% of couples will have achieved a pregnancy. And we know that the monthly chance of pregnancy, if it hasn't happened already, is pretty low. It's on the order of, 3 to 4% per month, just because we think that there's something going on, whether we know what it is or not. There's something that has prevented pregnancy from occurring already. So with IUI, we're really improving that, let's say double, maybe to 8 to 10% per month. But you're taking, time out of your schedule to come to these appointments, taking medication, doing an IUI for something that's 8 to 10% per month. So some couples might find that pretty frustrating. And the other thing to remember about IUI is we don't have as much control over eggs ovulating and sperm reaching the egg. So we do have higher rates of multiple pregnancies, like twins, from IUI, just because we don't have actual control over how many eggs of that group are normal and are those fertilizing with sperm. So higher risk of multiples, lower chance of success, but also less invasive. So it's a nice place to start. It certainly is a good place to start for people who also don't necessarily have infertility, right? People who, same-sex couples, people who are single mothers by choice trying to achieve a pregnancy, right? All of these, groups of people, it is a nice place to start. But if we're not meeting success with IUI, and some people may choose to jump straight to IVF, but IVF is really our next option. And with IVF, we're eliminating the way that egg and sperm kind of naturally meet in the body and doing that in the IVF lab. So we're stimulating the ovaries with much higher doses of hormones than our brain naturally makes each month to get one egg to grow. Our goal is to get multiple eggs to grow, right? We'll take as many as the ovary will give us that month. Now, it's really important to remember that the ovary has predefined the number of eggs that, based on your kind of total number, that it feels comfortable letting out that month. So we are only taking out eggs that are designated for that month, right? We're not taking out eggs that are, say, for next month, next year, 5 years down the road. So this is not like putting you into earlier menopause or affecting your future fertility in any way. And I always remind patients of that because I think that that's always a big concern. But we're taking out as many eggs as we can for that month and then fertilizing them with sperm in the IVF lab. And, this is also a solution for couples where the sperm is a big issue because we only need one sperm per egg. So we fertilize eggs in the IVF lab and we create embryos. And now we grow embryos to what we call the blastocyst stage. And that is the natural stage at which an embryo would implant in the uterus. And we can actually do genetic testing on embryos where we're able to learn, does the embryo have the right amount of genetic information, right? Because the wrong amount of genetic information is the most common issue that we see with female aging. So that becomes really important if the age of the female is higher or in, later 30s, early 40s. And then we can do an embryo transfer where we prepare the uterus and put that embryo that we've created in the IVF lab back into the uterus to implant. So that's kind of our two options. IVF is definitely the heavy hitter approach, so to speak. It is associated with much higher success. And I think the biggest benefit of IVF in my mind is that it lets you think about planning a whole family, right? Because you can freeze more than one embryo, right? So if somebody has infertility and we're worried, okay, that may also affect your chance of baby number 2 or baby number 3, we can try to address those all at once. And so when I'm treating patients, I really like to play the long game, so to speak, to really think about, okay, I know that we are focused on baby number 1 here. I know that this has been really hard and you've been at this for a year now or however long. And a lot of people come in and they're like, I wanted a family of 3, but at this point I'll have 1, right? And I hear that so much, right? But I also see the couples that then have the 1 and then they really want a sibling, right? So then they come back and then they're back in this place. And so the ability to freeze extra embryos for children in the future, I think is a huge advantage of IVF, particularly as people are starting their families later.
You kind of talked about how hard this process can be for couples. What do you actually recommend that they can do to support each other through this process?
I think the biggest thing is finding, your team, right? Like you want to say, okay, in times of stress, whenever I've had stress in my life before, right? What have I done to come out of that successfully, right? Who have I relied on? Has it been therapy? Has it been acupuncture? Has it been, daily conversations with a family member or a friend? And I tell people, like, recruit that team. Like, when you know that you are going to be going through this journey, get that team in place, make that therapy appointment, make that acupuncture appointment. It's up to them whether they want to share that they're going through this journey with close friends and family. But I think that support is really, really important. And, kind of recruit those people earlier on because I think this process is so multifaceted, right? It's not only the poking and the prodding, which, yes, I'm helping to try to address some of that with needle free IVF, but it's also like these really intense questions of, we've put all this money into this. How many eggs are we going to get? How many embryos? And then all of those answers take a lot of time to find it out, right? You're waiting a week for embryos to grow in the IVF lab when I don't have updates for patients. Like the embryos just have to grow. And that's grueling. And I remember that anxiety so well. And so, I tell patients to kind of try to stay busy, right? That's the time when if you have a weekend trip, take the weekend trip. Like schedule your meetings for those wait times, right? Where you're really busy at work or something, because they can just be grueling. So those are some of the things that I talk about with patients is just, making sure you're really talking about. The other thing is, this process is really, unfortunately, falls more on the shoulders of the female partner, right? And so I certainly felt this while I was going through IVF. I mean, my husband was in Northern California while I was going through all of this. And I remember being like, okay, you just get to show up the last day here and have the easy job. And so I think we feel like even though infertility is very much a team sport, like we talked about, the infertility treatment process or the IVF process feels very much like it's on the female and we are carrying the burden, the brunt of this process. And so I think people have a lot of feelings about that too. And so being able to talk about that and make sure that the male partner is also, acknowledging that, right? That we're being poked and prodded. We're taking, hours out of our work days to come in for appointments. And often I tell the male partner, like, you should try to be here too if you can. I know that they can't all the time, and that's fine. My husband was here for 0 of them, and I still love him dearly, and that's fine. But I think that just the way that the process is biologically, unfortunately, makes us feel like we have to carry the heavy weight of this. And I think that there's just a big mental toll on that, emotional toll.
So I know I said this before, but I am so grateful that you came on our platform today to talk about all of this. A big part of infertility, I think, is education, right? And a lot of people don't even have access to talk to someone like you. So I'm just so grateful that you've just explained so much to so many women who have so many questions about this important topic. So as we conclude, is there anything else that you want our listeners to know? And then also, where can they connect with you? Especially to learn more about what you do about this needle-free IVF. Yeah, it's amazing.
I think, what I try to tell my patients and kind of people who connect with me over Instagram or reach out over email is just that I think with your fertility, knowledge to the extent that is possible is power, right? And that preparedness and of course, the kind of wait and see approach sounds fun. There's, definitely a degree of spontaneity that fertility treatment can take out of building your family. But I think knowledge is power here and really preparing for the family that you want, particularly if you are starting a family later. I, see so many females where they're coming to me when it's much harder, right? And so I'm hoping that if we reach enough people who are in their, early to mid is and kind of have that opportunity to really be proactive and take those steps and utilize this technology for what it can provide, that we might be able to positively, influence how people, create their families and the success that they find in the end. How to reach me. So I'm active on Instagram. I love connecting with people there. I shared my own needle-free IVF journey and share a lot about, fertility and fertility tips and needle-free IVF there. My handle is rachel.mandelbaum.md. So if you want to follow me there and connect, I love connecting with people who have questions or want to follow along. And happy for people to reach out via email too. My emails are mandelbaum@havingbabies.com.
Thanks so much for coming on, Rachel. This was so great. I'm a big fan. So,
well, thanks so much for having me. This was so much fun. I followed as a fan of the Birth Squad for a long time and grateful to have been here.
Well, good luck on your other meetings.
Thank you.
All right. Talk to you later.